are in listen-only mode.
Good afternoon and good morning to you if you are on the West Coast. My name is Jose Leon, Chief Medical Officer at the National Center for Health in Public Housing, a project of North American Management. I want to welcome and thank you all for attending today's webinar, The Operational Site Visit, a Fiscal Perspective. This webinar is being recorded and the resources, slides, and other materials will be emailed to you after the webinar has finished. At the end of the webinar, we will have a question and answer session. I'd like to say thank you to HRSA for allowing us to make this webinar possible. The National Center for Health in Public Housing provides training and technical assistance to community health centers that are in or immediately accessible to public housing. Our mission is to strengthen the capacity of public housing primary care grantees and other health centers grantees by providing training and a range of technical assistance. Now, I'd like to get started and introduce our speaker of today's webinar. Karen White is a CPA and forensic accountant. She is an independent consultant specializing in medical practice management, community health risk assessment, and strategic planning in a healthcare environment, primarily for Management Solutions Consulting Group under contract with the U.S. Department of Health and Human Services, Health Resources and Services Administration, HRSA. She has conducted OSVs and TA assignments in over 200 health centers across the country. She participates in on-site visits to community, tribal, public entities, migrant, public housing, and homeless health centers to evaluate readiness to begin clinical operations, assess risk and compliance with federal regulations and statutes, mentor and evaluate CFOs and accounting departments, and train governing boards in their duties and responsibilities. Without further ado, I will turn it over to Karen. Good afternoon, Karen.
Good afternoon. Good afternoon, everyone, and good morning. Hopefully you can hear me okay. Welcome to this webinar. Thank you, Mr. Leon, and thank you all for joining me today. I know that the thought of an operational site visit brings a certain amount of anxiety. I mean, you have a health center to run, right? And now you've got to make time out of your day or out of your week in order to accommodate 3 consultants and possibly the project officer. However, if you look at it from HRSA's point of view, they're giving you a tremendous amount of money to run your program. HRSA must be able to demonstrate that they are doing their due diligence to assure that the health centers are complying with the 19 program requirements. They need the boots on the ground to assess the compliance. The clinic will have 3 experts on hand for approximately 2.5 days. Think of this as an opportunity for you, the health center. It sounds like some free technical assistance coming your way to me. Ask questions and make the most of the visit. Okay, let's get started with the agenda. So we're going to understand how the updated site visit guide impacts the compliance reporting. We're going to discuss key strategies for achieving compliance in the areas of technical difficulty, sliding fee scale, in the areas of financial management and control, billing and collections, budget, data reporting, learn how to prepare for the fiscal reviewer, and learn the most common not met for fiscal requirements. The site visit guide was updated in 2014, and it's the instrument that we use by all the consultants to perform the operational site visit. There is a new draft compliance manual, but at this point it's still draft, and so it is not into effect. So impact on compliance reporting. All elements of the program requirement must be compliant in order to obtain a status of met. No partial met, it's either met or not met. So if there are 25 elements in a program requirement and you meet 24 of them, but 25 is not met, it will be considered a not met. That is our charge. That is what we've been told how to conduct this site visit. So you will receive in the narrative credit for all the things that you're doing well, but then you'll have one section will say, this is what you're not doing, and then there will be step-by-step instructions on what you need to do to come into compliance. Their final reports no longer have performance improvement, but however, the consultants will continue to do technical assistance as time allows during the OSV visit. So the site visit tool should be used to prepare for the visit. So basically, this is an open book test. The preparation should begin at least 60 days before the visit. Suggested that you divide the guide between the senior staff, so their areas of expertise. The medical director will be looking at clinical, the CFO will be looking at fiscal, and the CEO will take the admin governance portion and then share among yourselves as appropriate. Go through all of the questions in the guide and answer them. That way you will know if there's any areas of non-compliance. This starting early will allow you time to make changes or to improve your documentation to ensure compliance. Public housing concerns. So as a public housing grantee, the Bureau expects there should be a service delivery site in an area immediately accessible to public housing for health centers targeting public housing residents. So you need to have one close by or inside the public housing. A question that we often get is, can you apply for a waiver of the patient majority board composition? So in order to get a waiver, you must show good cause that justifies the need of a waiver. It's usually difficult to get one for public housing because public housing residents tend to be more stable, and so it's difficult to have a good cause why you're not able to get representation on your board. So the first program requirement I'm going to look at is sliding fee discounts. So this program requirement has become extremely difficult to comply with since the Policy Information Notice 2014-02. So the program requirement states that you have to have a system in place to offer patient discounts, that you must offer a full discounts to patients at 100% and below with the federal poverty guidelines. You can only charge a nominal fee if you choose to, and patients with incomes between 100 and 200% must be offered a discount, and it must be based on family size and income. No discounts may be provided to patients with incomes over 200% of the federal poverty guidelines. And again, this is looking at the HRSA requirements. If you have maternal child health grant, then their requirements may be different, so you may have a different sliding fee scale for those kinds of visits. But as far as the HRSA programs and using the 330 funds, you could only offer a discount from 200% and below with the federal poverty guidelines. And then you also need to state that no patient will be denied healthcare services due to the individual's inability to pay. So some of the things that the consultant will review is they will look at your policy and they will make sure that it complies with PIN 2014-02. They will look at your actual sliding fee scale itself, so looking at your definition of income and how it's being broken down as far as where the discounts lie. They'll look at your signage that you have in the clinic and any brochures that you may have sliding fee language. They will look at the contracts for services where you have check mark in column 2 or 3 on Form 5B, and they will look at your patient fee and charge schedule. There will also be upcoming March 17th, there's going to be another webinar that's only going to be discussing sliding fee scale and Policy Information Notice 2014-02. So we may not hit every detail in this webinar because we'll run out of time. However, all the detail will be provided at a later date. The policy should include some of these items. You need to have a provision for waiving fees and nominal charges for specific patient circumstances. So for instance, in your policy, you need to state that this person, whether it be the CFO, the billing manager, the clinic site manager, whoever it is, this person has the ability to waive the fees for a patient, and then you need to give some examples of circumstances where the waiver would be allowed. You need to ensure that the patient privacy and confidentiality is protected throughout the process. In your policy, you have to define family and you have to define income. So HRSA does not tell you what it needs to say or what your definition of family needs to be. It just says that you have to have a definition. So you could use whoever lives in the household. You could use an IRS definition. It doesn't matter. Whatever it is that your health center wants to use as a definition needs to be in your policy, and of course it needs to be in your practice. You need to have language describing the specific structure of the sliding fee discount schedule itself, and then you need to state that it applies for all in-scope services that are listed on Form 5A. The sliding fee scale must have at least 3 discount pay classes above 100% and at or below 200% of the federal poverty guidelines. So basically what you have as a minimum is 5. You'll have 1, 100% and below. You'll have 3 between 100 and 200%, and then the 5th one would be over 200% of federal poverty guidelines, no discount. The discount classes must be tied to graduations in income levels. The fee schedule. So we'll look at the fee schedule. We'll ask questions such as, when was the last time it was updated? What method did you use to set the fees? Did you look at local prevailing rates? Do your fees cover your cost? Did you use an RVU method? Did you look at a percentage of Medicare fee schedule? Did you use like a fee analyzer or something? Just what was the process that you used to set your fees? The nominal fee. So this must be a fixed flat fee. It's not a percentage or a range, and it cannot be more than what the next person in the next category would charge. So at 100% and below, that is your lowest fee to all patients. The next category up, so 100% and to X, that amount has to be more than your nominal fee. And of course, the nominal fee is not reflective of the cost of providing the service. It is truly just a nominal fee. And the PIN is very specific. You have to use the word nominal fee. You can't say a minimum fee. You can't say minimum charge or copay. It has to say nominal. So program requirement number 12 is the next one that Fiscal will look at, and that is financial management and control policies. So this has got a couple of different parts to it. One part, we'll be looking at your accounting and internal control system to make sure that it's appropriate to safeguard your assets and to maintain financial stability, and then also to make sure that you have an annual audit, and if there are any issues with your audit, that you file a corrective action plan. So this program requirement, the consultant will look at your accounting policies and procedures. Usually they want to look at those in advance so they can read them on the plane or at night over the weekend. They will want to see your most recent federal audit. And if there were any findings or question costs, they will want to see your corrective action plan. They will want to talk to you about your system of internal controls. So basically what they will do most likely is they will walk through the accounts payable and the payroll cycle. They will want to know such things as who approves the orders, who approves the invoices, who has access to the check stock paper to write accounts payable checks, who manages the vendor files, again, the vendor files that are inside of your accounting software, who prints the checks, who signs the checks, are 2 signatures required, who mails the checks, who reconciles the bank, and then who reviews the reconciliation. So if all of those processes are done by one person, then obviously that's a problem because there's not adequate internal controls. And when looking at internal controls, we're not looking at people, we're not looking at personalities, we're looking at job duties and job tasks, because the system of internal control should be in place regardless of who sits in that chair. Because we all look around and say, well, Susie will never do this, or this person will never do that. That's fine, but we're looking at the big picture. We're looking at the future. We want to make sure it doesn't matter who sits in that chair, that they don't have the ability to do something inappropriately. They will look at your financial statements. So they're going to want to see what you provide to the board of directors and to the finance committee, whether it's just a profit and loss, balance sheet, do you give any kind of ratios, do you look at patient numbers, payer mix, whatever kind of information that you give to your committees. And they will also want to talk through and look at your system for tracking federal transactions. So some of the policies that the consultant will be expecting to see is a policy on audit. And there's a later slide, so I'll go to that in more detail in just a moment. They will want to know that you have a federal drawdown and a grants management policy. And so for this policy, they'll be asking things like, we're expecting to see, how do you determine how much money is drawn down? How do you determine whether a cost is going to be paid for through your 330 grant or whether it's going to be paid for by program income or by another grant? How do you manage your grant? How do you make sure that you're in compliance with the grant requirements? Do you track your total drawdown so that you know how much money you have remaining in the grant so that you can make sure that you spend all the money in the grant during the project period? They will look at internal control policy and segregation of duties. So making sure that you have all the things that I talked about earlier, make sure that you have those kinds of things in your policy. And again, when you do policies, you want to do job titles. You never want to use people's names. You want to keep it so it doesn't matter if there's a turnover in your staff, but you still have the duties of that person under that title. Looking at your procurement and purchasing policy. So wanting to know how purchases are made, what the approval process is, the oversight of the process, if there's a bidding process for capital projects, things like that. So just all of the details of procurement or purchasing. Contracts. There's a program requirement separate, program requirement number 10, which is just dealing with contracts. However, typically the contract policy is under the fiscal regime, so that's why it's listed here. So make sure that the policy reference or include a conflict of interest provision. The conflict of interest provision is for directors, employees, and agents. A lot of times what we see as agent is not included, but think about it. If you have a contract CFO or a contract medical director and they're in a position where they can make decisions on purchases, you want to make sure as a health center that these individuals declare any kind of conflict of interest so that they're not making a decision as your health center CFO or CMO or some other management staff that will influence a company that they're affiliated with or a relative that would benefit from that decision. So all the contractors must declare any potential conflicts, and they must have appropriate procurement and oversight over contracted services. You want to make sure the contracts don't limit the health center's authority or compliance with program requirements. Also, there should be a policy on budgeting. So it would just be an overview of the budgeting process. You know, who's involved and at what point are they involved. So is the budget done by the CFO and the finance department, and then when they have it completely done, then does it go to senior management for review? Or do you have senior management and or department managers involved in the actual process itself? Just what is the process for doing the budget? Does it go to the finance committee for approval and then to the full board? So just talking through how you come up with your budget and the approval process. Financial reporting, so a policy just stating what kinds of financial reports are run on a monthly basis and who were those reports shared with, whether it be senior management, department managers, finance committee, the board, etc. And then there's also a lot of other general accounting type policies, and so just kind of as a laundry list of some of the things that we'll be looking for: overview of the accounting department and the accounting processes, chart of accounts, bank reconciliation policy, check signing, accounting software setup. So are you set up in segments? What kinds of things do you track separately in your GL, whether it be location codes, department codes, etc.? What kind of insurance coverages do you have? Credit card usage, travel, accounts payable, revenue recognition, inventory, payroll, and record retention, to name a few. So you want to make sure that these policies are updated. So it's a good idea, prior to the site visit to read through all of your policies to make sure that they actually are still in effect right now and not 5 or 10 years old. And then you want to have board approval for those policies that you change. Typically what we look for is all policies should have board approval periodically. And depending on who you speak to, that's usually between every 2 to 3 years. So that doesn't mean that your board has to review all policies every 2 or 3 years. However, you bring the policies to the appropriate committee. They will review the changes that you make, and then the whole booklet or set of policies will go to the board for full approval. You want to make sure that each policy is signed, dated, and approved by the board and documented in the board minutes. So again, if you have all of your fiscal policies in one booklet, so they're all together, then you can have the board sign the last page or the first page, however you have it set up in your system. But just make sure that in the board minutes, it lists all of the policies that were approved. Federal audit. So you must have an annual audit that complies with A133 compliance. The rules have changed for audit requirements now with the Circular 200. You only
Saki, can you ask Saki if she can hear him?
there is a difference between the two rules. The board needs to select the auditors. Again, this should be in the audit report. And then once the audit is done, the board accepts the audit. So most of the time, the CFO will do the research and do the legwork as far as getting quotes from the auditors, and then the final decision is made by the board. But they don't do the legwork on that. Every 3 to 5 years, you should take the audit out for bid. However, there's no regulation that says that you must. And if you do take it out for bid and you still want to stay with your same auditors, that's okay. You don't have to change auditors even though you've taken it out for bid. It is a good idea, though, to have a different audit manager or senior person for your audit. That they should change. That person is to change every 3 to 5 years. If there are any findings or question cost, reportable conditions, or material weaknesses, then you will have to do a corrective action plan, and that plan must go to the board of directors, so we will look for that in the board minutes, and then we would expect to see periodic updates saying the corrections have been made. Tracking federal transactions. So we'll want to know how you track your federal and non-federal transactions. Do you keep them in a spreadsheet? Do you have them in the general ledger? So can you run a profit and loss report from the general ledger? That is what we expect to see, that they're tracked within the GL. Financial statements. So making sure that the statements reflect generally accepted accounting principles. Well, again, like I mentioned earlier, we'll look at the reports that you provide to the Finance Committee and Board of Directors. We'll want to assure that the board is getting financial information on a monthly basis. We will want to see if the Finance Committee is meeting monthly, and if so, are minutes kept, and do minutes document discussion. Again, these are all to show that the board members are doing their fiscal due diligence for the health center. Billing. So making sure that there's a system in place to maximize collections and reimbursements for its cost in providing services. That includes written billing, credit, and collection policies and procedures. So the consultant will review the following: the billing policies and procedures, the accounts receivable aging summary by payer source. They will want to make sure that everything is in compliance with Policy Information Notice 2014-02, and they will also look at the UDS. So the sections of billing that's covered under PIN 2014-02 will also be covered on the March 17th webinar. So you must document reasonable efforts to collect and to receive reimbursement for the cost of providing services. You have to participate or show that you participate or attempt to participate with Medicaid, CHIP, and private third-party payers. However, if a private payer does not offer a reasonable contract, that does not mean that you have to accept it. It just means that you need to try to participate as appropriate with the plans that your patients are bringing to the health center. You also need to make reasonable efforts to collect payments from patients, but again, not to make it a barrier to care. However, there should be an expectation that patients would pay their share. So you do need to ask patients for their copay, their nominal fee, or whatever it might be. The consultants will also review your accounts receivable aging schedule, and they will go through that, and they will want to know if there's anything that's older than 120 days, and it could even be 90 days. They will want to know that you know what's going on. So if you have a large balance in Medicaid that's 120 days old, and the consultant will ask you about that, and you should be able to say, well, the reason why it's this old is because we just added 3 months ago, we added 2 new providers, and those providers are not credentialed with Medicaid yet. Or we just opened a new site and we're waiting for their certification for it. So you should be able to explain and have a reasonable explanation about why the balances in certain categories or certain buckets might be higher than others. Billing policies, so you must have written policies and procedures addressing billing and collections. So such things as, how frequently do you process claims? And we're looking for a number. So do you do it daily? Do you do it twice a week? How often do you actually process the claim? We will also want an overview of the billing process. So again, that would include the frequency of claims submitted, frequency of payment postings. So do you post your payments every day? Do you post them once a week? How often do you do that? How are denials worked, and who works those denials? And how do you know that those denials are being worked and not just being ignored? How do you work your old accounts receivable? Who looks at it? What's the process for working that AR? And then how does the billing manager, how do they manage their staff? How do they know that they're actually doing something and not just busy work sitting at the computer? We want to also know how you assure that all the claims are processed and billed. So looking at such things as, what reports do you run? Do you run on a at least weekly basis an open encounter report or an unclosed record report? How do you know that when the provider sees the patient that they do everything they need to do, they sign and or close the record so that it can then be billed? So backtracking to make sure that everything is being billed. Can't tell you the number of times I've gone to a health center who don't do that, and they run the report and they find hundreds to thousands of claims that are sitting there that have never been billed. Encounters that have never been billed because the record wasn't closed or the records were incomplete. So you do need to do that on a very routine basis and have someone that it's their responsibility to run that. More and more, I'm starting to see that it's being done on a site-by-site basis, and it's being done by somebody at the front desk or the site manager on a very routine basis. You need to have a provision in your policy for waiving charges or nominal fee. So again, that is who's able to do that. And one to waive the fees. Refusal to pay, that is not required. However, if you do have a refusal to pay policy, it must include the following: what constitutes refusal to pay, what individual circumstances are to be considered in making such a determination, what collection efforts are to be taken when these situations occur. Do you offer grace periods, set up a payment plan, have patient meet with financial counselor? So all of those things have to be included if you have a refusal to pay policy. Again, it is not required. Budgeting. So you must develop a budget that reflects the cost of operation, expenses, and revenues necessary to deliver your service. The consultants review the following. So they'll look at the most recent 330 grant budget with forms. They will want to look at your current operating budget with assumptions. They will want to look at financial statements comparing actual to budget. And they will also look at the UDS. So on the budgets, again, as I said, they will look at both the 330 budget that will be part of the application, the most recent application that had been submitted to HRSA, and the operating budget. Those could be the same, but in most cases they're different depending on how big your organization is. We'll look at, on your operational budget, we'll look to make sure that the federal funding match your most recent NOA. And again, we'll line up dates. So whatever NOA would have been in effect at the time when your budget was created. We'll want to know what assumptions that you used to develop the budget. So did you look at the number of patients to be served, the number of encounters, the payer mix? And if so, how did you do that? Did you do that based on site? Did you do that based on department? Did you do that based on provider? How was those assumptions come up with? Did you involve the departments and or sites or the medical director? Just trying to hone in on where the data came from and what the basis were for your assumptions. And then look at your calculation for net patient revenue. And again, that's where we can kind of look at the UDS to see kind of what your collections are and what you were last year compared to where you think you're going to be this year. Your personnel and benefit cost, we'll look at what assumptions were made and who is included in the federal grant. And then how are you tracking their time to make sure that that's allocated to the federal grant appropriately. And then, of course, other expenses. And then we'll just check to see if the operating budget shows a profit. And again, the expectation is that you will be profitable. You are a business. Even though you're a nonprofit is a tax status. It's not a business strategy. And in order for the health center to be there for tomorrow and to be able to continue to provide services to their patients, they need to be profitable. Do you have budgetary controls in place? So are you doing comparisons between budget and actual? And then when they start to move in opposite directions, do you look at that and analyze it and then either A, revise the budget, or else come up with a plan where you can either increase your revenue or your patient numbers and or decrease your expenses as appropriate? Do you keep a federal drawdown schedule? To share that with the Finance Committee on a periodic basis? Again, the danger here is that we want to make sure that the health centers are drawing down the funds in a reasonable, periodic manner. We don't want to go into the health center, 6 months into your grant budget period and find out that you've drawn 100% down of your grant. So just being able to make sure that you're, in line. Do you have to be exact? No, but just so that it's a reasonable amount. And does the Finance Committee and or Board of Directors receive a profit and loss statement comparing actual results to the budget? And that should be done on a monthly basis and on a year-to-date basis each month. So on a monthly basis, they get, for instance, the month of January compared to budget and year-to-date January compared to year-to-date budget. One of the last program requirements that the fiscal person looks at is program data reporting. So making sure that the health centers have systems in place to collect and organize data. and that support management decision making. So do you have systems in the capacity to collect the data required for filing the Uniform Data System Set report, the Federal Financial Report, and to track clinical and financial performance measures? So and nowadays everyone has an electronic health record, but whether or not you can get the data out of your record sometimes is more problematic. Using another software such as I2I or Bridget or something is totally appropriate. We will, on site, at least one of the consultants will ask for a report of current information. It could be a current number of patients and payer mix. It could be a current clinical measure, something like that. I will almost guarantee that somebody will ask for some kind of a data report, and they will want to know that you're able to run it and get the information. And then also, we'll want to have some examples of how the data is or was used to support a management decision making. So for instance, an easy example would be, that you ran a report and found out that your no-show rate was 30%, and that was much higher than what you expected it to be, and much higher, of course, than you want it to be. So you come up with a plan to try to lower that no-show rate. So perhaps if you've got multiple sites, for one site you decide, well, let's do patient reminder phone calls, or let's limit that you can only schedule out 2 weeks in advance. Whatever it is you do that for that site or for your whole office practice, and then at the end of X period of time you do a reassessment to see if it worked or not. Then if it worked, great, maybe you bring it over to all of the sites, or no, maybe it doesn't work, and then you try something different. So just kind of a brief synopsis of a problem that you found, and then what you did to try to make it better, to fix it. So some of the most common not mets are program requirement number 7, which is sliding fee scale. A lot of times what I find is that the policy doesn't include the required language, so it doesn't include things like the definition of family or income. It doesn't include information about the sliding fee schedule itself. So any of the number of things from the sliding fee, it's just not included in the policy as required from PIN 2014-02. The sliding fee scale itself is not compliant, so perhaps you don't have the 3 categories, or you offer a discount for patients who make more than 200%. Your fees or your charges do not cover your cost, so maybe you haven't changed your fee schedule in 10 years, and it has no reflection on what the cost of providing services. And that you don't document how the health center assures that the nominal fee is nominal from the perspective of the patient. So this is something usually it is done by the board of directors, and it should be put in the minutes. The other most common fiscal not met is program requirement 13, which is billing and collections. So what I normally find is that the billing policies and procedures, they don't describe the billing processes. They don't have in place an insurance that all the charges are billed. So in preparation of an operational site visit, so plan on preparing the documents in advance. Use a flash drive or a Dropbox or some other method to share the documents. The consultants typically like to look at each other's. So for instance, as a fiscal consultant, I will look at some of the administrative documents. I will look at the board of directors minutes that the admin person has asked for. For the clinical, I may look for contracts that are not included in mine that they've included for clinical. So we do like to look at each other's information. So if you make flash drives, make 3 of them exactly alike. And if you have Dropbox, of course, we'd have access to everybody's Dropbox information. You want to cooperate with the consultants by asking their questions and providing the requested information. If you don't understand something they're asking for, please ask. They'll be happy to clarify it for you. And just plain common courtesies that you would use for any guest that comes into your office. So it's fine if you normally would offer coffee or water to do that for the consultants. That's not a problem, but just treat them as you would a guest. You want to make sure that you have a workplace or workroom reserved for the team, so they will need a place to work. The ideal would be a small conference room where they all like to sit together in the same room because there's a lot of conversations between the group. They do need to have access to the internet because the program report is now online. And then, of course, you always have to plug in your computers, so access to an electrical plug. And then for the visit, be transparent and communicate. Anticipate that the financial consultant will meet with the CFO, they'll meet with the billing manager, they'll meet with either front desk staff or the eligibility staff. The conversations with that staff are typically very short. They revolve around the sliding fee scale, who is offered the sliding fee scale, if it's offered to patients with insurance or just for uninsured patients, and just the documentation of what is required in order to apply for or to be accepted for a sliding fee discount. Again, that information should all match the policies and procedures that you've already shared with the consultant. And then they will also talk with the IT manager for a short time, and typically about such things as backup procedures, and whether or not the software is hosted on the local servers or whether they are outsourced on another server. So just kinds of those relationships. It's pretty 10,000 feet level type of questions that they ask IT. Again, it's in your best interest to work with the reviewers and to view the operational site visit as an opportunity for improvement. Again, you're going to have 3 experts at your health center for 2.5 days. And so now is the perfect time to get answers to your questions. They obviously don't know everything, but they've all been to a lot of health centers and they have access to resources that they could share with you or just be a sounding block for maybe a problem that you have, your health center, a challenge that the health center has that maybe you want just a fresh opinion. Doesn't mean that you're going to take everything they say, but it might get you start thinking on a different avenue, think outside the box, so to speak, to come up with a solution to a challenge that you've had. So here's just a few resources that I've included. So the site visit guide, the training and technical assistance website, and then the compliance manual is listed here. So that is the end of my presentation. We've got time now for some questions, and I'll turn it back over to you, Jose.
Thank you so much, Karen, for this wonderful presentation. We have some questions, but there has been a hand raised for 23 minutes from Edgar. So let me unmute his line and see if he has any questions.
Okay.
Edgar, can you hear us? Well, it seems that probably he doesn't have any questions, Karen, but we do have some questions here. Let me read the very first one. We have a question that says, this is a very helpful list of preparation questions for the finance portion of the site visit. Will these slides be distributed to attendees? The answer to your question is yes. After the webinar, we are planning to send all the materials to all who have registered for the webinar. Those are the 3 questions that we have so far, Karen. There is another one. This is in regards to the sliding fee scale. The question is, can we have a separate sliding fee scale for different services, service categories?
Yes, you may. You can have one for medical, for dental, behavioral health.
Okay, so let's see if there is any other questions. Again, we are getting some questions in regards to the copy of the slides. After the presentation, we're going to email the slides to all attendees. There is another question, Karen, says, if I have subrecipients, should they be using our sliding fee scale too?
Yes, the subrecipient must follow all of the program requirements that the health center has to follow. Their sliding fee scale most likely will be different than yours, but it still has to meet the requirements of PIN 2014-02. So it's a health center's responsibility to make sure that the subrecipients are in compliance. And when the team is on site, they will be, if you do have subrecipients, they will ask questions. And on some instances, they have visited a subrecipient site. It all depends on the makeup of the organization.
Great, thank you so much. There is another question. The question says, can a health center have a different nominal fee for a special population?
If it's in your policy and it's board approved, normally for a special population, what I often see is like if you have a homeless or even public housing population, you may have a zero nominal fee, and that is fine. Just have it board approved. You could also say in your policy that the nominal fees are waived for all homeless patients, for instance. That's usually there's not an issue with that. But again, it needs to be in your policy and be board approved.
Great, thank you so much. There is one more question. It says, in our dental services slide about the 100% category, we charge a percentage of charges with a minimum that is our nominal charge. Does this comply if a patient ends up paying the minimum amount rather than the percentage of services?
So for patients at 100%, I'm not quite sure I understand the question, so let me answer and then that person can let me know if this answers their questions. For patients that are 100% and below, for dental services, you still have to have a flat nominal fee. However, you can add the cost of equipment or appliances. So if you do dentures, you can add the cost of the dentures. If you do a crown, you can add the cost of those crowns. So it can be a nominal fee plus the cost of. For patients that are 100% at 100%, above 100% and below 200% of the federal public guidance, you must offer a discount. It does not have to be a flat fee. It can be a percentage of charges. And then patients 200% and above, of course, no discount is allowed with the federal funds.
Great, thank you so much, Karen. And Lisa, if you have any additional questions, you can type your question, or you can send us an email either to Karen or me, and then we will be able to give you additional responses. Now, there is another question. Karen, it says, do providers for referrals in column 3 on Form 5.8 have to have the same or better SFS?
So for column 3, that means that the health center does not pay for the service, so the patient is paying for the service. So you do have to, for those services in the contract, it has to either be better than the health centers or it has to meet the program requirements under PIN 2014-02. In most cases, if you're referring to a hospital with their charity care policies, they are typically better than the health center policies, and so usually that's not a problem, but it's a little bit more difficult to get some of your specialties to comply. However, you only have to worry on Form 5A, column 3 especially, you just have to look at required services. So, for instance, if you have a contract with a cardiologist, and that cardiologist won't offer your patients the same sliding fee or better, you don't have to mark cardiology on your Form 5A. It could be considered an informal agreement, so you have an avenue for your patients to go, but it's not listed on Form 5A. We're looking at the required services. So if it's like OB and delivery, that's required service, so your contract does have to comply. But any of the specialties or subspecialty services, you don't have to include those on Form 5A.
Great, thank you so much, Karen. And Lisa wrote back and she says, no, if someone is at 150%, they might have to pay 50% of their charges. But that might not be over the nominal charge, and then they pay the nominal charge amount. Does that make sense?
That does make sense, and no, you're not able to do that. Your nominal fee has to be less than what any other patient would pay in a higher category. So that would probably say that your nominal fee is too high. But you can also look at the bundling types of services. So an office visit is more than just an exam. It could include x-rays, etc.
Okay. There is another question here. Karen says, the question says, we are looking at adding a mobile health unit. Can we offer a different sliding fee for those services provided in the mobile unit?
That one's a little bit more gray. Typically, they want to see the same sliding fee throughout the organization for the same type of service. I think to justify a completely different sliding fee, it'd have to be in a different service area, or you'd have to be able to give a reason why it needs to be different than everyone else's. So if you're providing medical services in the mobile unit and medical services in your clinic, why do those sliding fees need to be different? And I'm not talking necessarily just about nominal fee, but I'm talking about the sliding fee in general. You'd have to be able to justify why.
All right, thank you so much. There is another question. It says, operationalizing discounts to ensure patients get lots of questions on how to do it at health centers. Can you give us a good example?
Jose, could you repeat that question again,
Yes,
please?
it says operationalizing discounts to ensure patients get lots of questions on how to do it at health centers. Can you give a good example?
I'm not sure what they're asking. Are they just asking how to operationalize the sliding fee scale, or are they having patients ask them why there's a discount? I guess I'm sorry, I don't understand the question.
All right, Lisa, there we go. It says, clarifying for those insured patients that are eligible for SFS.
Okay, great. That makes sense. So if a patient has insurance and the health center has gotten their income information from them and they qualify for a sliding fee scale, the way it works is that the insurance is billed first, and then whatever is not paid, then whatever is remaining the sliding fee can be applied to that. And as far as giving discounts on copay, so for instance, let's say your nominal fee is $20 and the copay for this person who qualifies for a nominal fee, let's say, so 100% or below, if their copay is $35, what the Bureau says is that you should discount it to $20, your nominal fee, if the contract allows you to do that. But in most cases, contracts with third-party payers will not allow you to discount the copay. So you just have to look at your contract. But the way it works again is that you do take the insurance and you bill the insurance company, and then you slide the remaining patient balance. And you want to bill the patient's insurance because at some point they may go to the hospital or an outpatient. You want to start chipping away at that deductible, and who knows, maybe by the end of the year the health center may start getting payments from that insurance company because the deductible has been met.
Great. Thank you so much, Karen. And there is one more question. It says 3 out of 4 of our FQHC sites utilize an outside lab. We have an MOU with this company. Does this company have to meet the requirement of PIN 2014-02?
No, not for a lab. Typically, the agreement with the lab company, a lot of times the labs for patients 100% and below, a lot of times the labs will have a discounted fee schedule and they will bill the health center directly, and then the health center will cover those costs for 100% and below, and then the labs discount, they will be offering a discounted service to the patients at between 100 and 200%, a discounted cost. All the lab charges are a little bit different contracts. There's a lot of labs companies, if you're a very large health center, they will actually slide or not charge the patient or the health center for patients who are 100% and below with their federal poverty guidelines, and sometimes they will even go up to 200%. So it's definitely something that you want to talk to your lab about to try to garner some additional discounts.
Excellent.
Keep in mind if you're...
Excellent. Thank you so much, Karen. We don't have additional questions in the queue, but if there is anybody attending this webinar and you would like to ask a question, so you can send a question to Karen or you can send it to me at jose.leon@namgt.com, and I will make sure that Karen receives your question. So Karen, thank you so much for this wonderful presentation. Once again, we need people like you to keep us abreast on topics like the one that you have just presented. And for all attendees, if you have any questions, again, make sure that you send them to the National Center for Health and Public Housing. You can also visit our website, www.nchph.org, where you can find information on webinars, monographs, newsletters, information on our conference, and information on one-on-one training and technical assistance. You can also join our mailing list, or you can follow us on Twitter, or subscribe to our YouTube channel. And once again, thank you so much for this wonderful presentation. If you have any questions, this is our contact information. And please do not forget to complete your the post survey. This information is very critical for us to improve our webinars. One more time, thank you so much, Karen, for your presentation, and have a good afternoon.
Great. Thank you, everyone. Thank you, Jose.
Thank you.